Well, thank you. Thank you for the introduction, and thank you, the organizing committee and the IFSO European chapter for the invitation to be here today and talk about this topic, which is very interesting. And to be honest, I start digging a little bit in this topic when a few years ago they gave me this talk for another Congress, and I said, well, this is something difficult. And at the end, I'm working in the hospital to run changing the philosophy of how to deal in the OR with this concept of sustainability and innovation. So it is important, but it's not important for IFSO. It's also important for everything. If you go to internet and you check and you say, you put the 10 popular academic event themes in 2027, you can see that innovation and sustainability are there as one of the major lectures in congresses of any kind, in any kind of congress, whatever it is, economics, financial, bank, medicine, whatever, innovation and sustainability are two words that are really together. And if you go to ChatGPT and you ask them what are the most important topics in events, you can see again that innovation and AI are together and sustainability is one of the main topics. So it seems that it's very popular to talk in the different events about innovation and sustainability and put it together in this concept regarding bariatric surgery and how to deal with these two topics. So sustainability is important today for different reasons. And you can see that the world is changing and there is a lot to be done. So you can go and you see in internet, you see in the news, you see that so many things are happening, and still there is a lot of waste that is not properly treated, and there is a lot of climate change that affect us a lot. So you can see that there is a real impact of this sustainability in our daily life. And in fact, you can see that the climate change is happening because of that, because of those waste that we are throwing to the world, to the planet, and we are having really problem with that. So, but these problems have an impact in healthcare system, and you can see that 23% of the deaths are due to modified environmental factors. So there is a lot that can be done for the health system. And in fact, if you analyze what happened in our hospital, you can see that the healthcare system, 8% are responsible to 8% of total greenhouse gas emission. So healthcare system also, they try to solve the problem, but they produce the problem. And this is one of the main issues that has to be analyzed. And one of the things that really impressed me is that most of the problem produced by all this is the energy we use in the hospital to maintain the hospital working. So there is a lot of problem related to this energy that we use. It's not green energy. It's not energy. It's producing a lot of problem. But we as surgeons, we have to know that 30% of the hospital waste and the problem produced in our hospital due to our work of what we do in the OR. So there is something that we can add the system, we can add the hospital, we can support the hospital, we support the society to change what is happening in the world. Because the problem is, even that we have a lot of instruments that are fully recyclable and so many things that we use in the OR, we don't do anything because they go to incineration and landfilling. So at the end, we try to do a lot of things. We ask the company, please give me a green package for my EndoGIA, but we throw it in the wrong way. So at the end, it's our fault. Because the companies, to be able to sell it, they have to have the green cover to the cover of the instrument. And even in the instrument, they have to have a green mark. So they follow the rules. The one who doesn't follow the rule is ours, is our managing director and is ourselves in the OR. So there is something that we can do. I will give you an example. This is a sleeve gastrectomy that I performed a couple years ago. So clean, 30 minutes, no problem. Everything went really good. The patient did really good. But I told my scrap nerd and he said, listen, why don't you throw like a blanket in the OR and try to put paper, try to put plastic, bottles, everything in the different places. So this is what happened in the OR. Look at what we found. So there is a whole amount of waste that we did just for a 30-minute surgery. This was a bariatric surgery. But you can see how much waste we produce. But not only us, also the anesthesiologists, all the crystal bottle, all the needle. And then I told them, when I finished the surgery, I said, listen, now try to collect the way you normally do it. You know, the way you normally do it. So in my house, if I do that, that was Sunday after the sleeve gastrectomy, that it was a Friday. That was my house, nice jamon. So we have a nice dinner. And at the end of the day, we finished with everything in each basket. And I took everything to the right place. But when I finished the surgery, this doesn't happen in the OR. So they did what they normally do, and they put all together in the same basket. So this is what it shows. And I'm pretty sure that no matter what you do, this happens in most of the hospitals where we work. And I can tell you that I work in different hospitals, and this is the way it is. I've been doing live surgery so many places in the world, and they all the same. Sometimes to justify what we do, they have a small basket and they said glass or whatever. But at the end, this is what happened. And I remember talking to my manager director of the hospital, and I told them, I want to have a green OR. He said, what are you talking about? I want to have different, Salva, do whatever you want. I don't care what you do. But as long as you operate and the waiting list is okay, you can do whatever you want. So they give me green light, but they give me green light without any resources. So it's very, very, very complex. And there are so many persons there that my assistant, my colleague, they didn't believe in that. My scrap nurse, there are so many people. And to control that in a huge hospital, 1,000 bed, it is really complex and very disappointed. So, but this is all about recycling. We are not recycling. We force the company, and the government forced the company to have all these green stamps on the covers and on the instrument, but we don't follow what we ask for. So this is something that we have to be conscious. But this sustainability, there is so many little things that are also important, and it's the impact of complication in sustainability. And this is important because the bigger potential impact of sustainability is based on reducing complication. And this is also very interesting to analyze. Gastric bypass, you see this gastric bypass, leak, and this happened the other day checking with methylene blue. And you can see that good things that I check, because when I check with methylene blue, you see what happened. So I avoid a leak, a social impact on me, myself as a surgeon, on the patient, and on the family. So I was so happy that I checked this with methylene blue. So I think there is a very important social impact on preventing complication. But on the other side, on the economical side, there is also an economic impact. And there is a paper from Blas Flor from Valencia. It's about colorectal, but it's very interesting to see how for each leak that we save 44,000 euros. So there is a lot of money when you have a leak. And from the environmental impact, you can see also that we save a lot of water, CO2. So water, CO2 concept that is difficult to understand for us. But if you take that to this chart, you can understand a little bit more. So you save CO2 of 5 flights from Denver to Chicago. You save water, that is the amount of water used 6 times the amount of water of an American person used during a whole year. And also the waste that you produce is 2 times the monthly waste generated by a US citizen. So there is a lot, and this is just one complication. So one leak. So there is a very important impact, economic impact, environmental impact of that. But not only leak, Also surgical site infection. You can see surgical site infection, you see all this number, but again, by avoiding one complication, you avoid 10 flights from Madrid to Barcelona, water 18 times of the annual water of the Spanish citizen, and a lot of waste. So you see that avoiding one surgical site infection, you save a lot of money. This is a video that is in internet. This is a Dutch patient with a surgical site infection of a breast surgery, and she collected everything that it was used to clean the surgical wound. So look the amount of plastic bags, covers that it were used to check and to save and to clean that surgical site infection you have after the breast surgery. So it is impressive. So you can understand that we have to do something. But not only that, what about bleeding? Bleeding also is a complication. You see the amount of bleeding for each 1,000 procedure depending on the type of procedure. And you can understand also that surgical bleeding in 1,000 patients of cholecystectomy, whatever, you can see how much we can save. So it's a lot of CO2, water, and waste. So our first goal as a surgeon is to avoid the social impact on yourself, family, and the patient. But if you go deeper, you can see how much impact there is, economic impact and environmental impact of what you do. So I think that sustainability, besides recycling, is something else, and you have to be linked to innovation. Because if you use in the proper way innovation, you save a lot of money, and you do a favor to the environment. And this is very important for innovation. So I think innovation to decrease leaks, infection, and bleeding, to decrease complication, it is important because there is an impact of what you do. We know that robotic, AI, image-guided surgery, they are expensive, very expensive. But this is what I try to explain to the manager director in my hospital. So even that is expensive, I'm saving a lot of money to the hospital, and I'm helping the environment to be more green. And this is the message that you have to use, because it's the way that, in a way, it is important. And that's the reason why using innovation, you have to measure outcomes. You have to measure outcomes because if you have to measure outcomes, you can sell the concept that I'm doing something for the economical system and also for the environment. But if you don't measure outcome and the impact of this innovation, it's impossible to understand the concept. Because every time we come with an innovation, we have to justify. And for that reason, you have to measure the outcomes. So I think innovation, the way we have to give value to innovation is that we decrease complication. And this is very, very important because we will make more sustainable surgery. So you understand what I told you. We have to work, but of course, as a surgeon, we cannot do anything. But we have to understand that the hospital have to change in terms of energy. We have to use green energy and be more efficient. How many times, 2 o'clock in the morning, you are on call, you work in the hospital, all the lights of the hospital, every single room are on. And you know what I do? I keep off. So do I doing anything for the hospital? I don't know. But someone has to do it. Sometimes we have to think, and if you come back home and you start thinking and you work in the whole of your hospital and you keep understanding what is wrong in the hospital, you will see that there are so many things that are being done wrong. This concept of a smart hospital, telemedicine, digitalization is very nice, but it's even more nice of what we think. Look, this is the pathway of a bariatric patient, preoperative, intraoperative, postoperative. These things about apps, wearables to control and to prepare the patient, optimize the patient for the surgery and do the follow-up, it is important to follow because it's a green concept, it's a green pathway. You don't need the patient coming to the hospital, leaving to the hospital, producing CO2 and producing all this. So we have to look at it as as something that we're doing for the planet. So beside that, also waste reduction and recycling. So this will be intraoperative together with the follow-up and the optimization of the patient is the way to follow. There are companies working on that. I'm going to finish. And in the OR, you have to think that most of the instrument can be recycled. You see a endo-GIA, how much can be recycled? Almost 100% of the endo-GIA can be recycled. We don't do anything. Harmonic scalpel, trocar, so many things can be recycled. So just to finish, take this at home. Digitalization of the pathway. We can work in the energy of the hospital, optimize the equipment, recycling, and waste reduction. I think this is very, very important. So innovation is not sustainable if we don't improve the outcome and avoid complication. And this is something that is in one of the brands that we use of our cloth that is very important. Just work on that because we don't have a planet B. Thank you very much.
Thank you very much for opening our eyes to the real big problem. It's amazing to see. And there are some questions, please. Okay, maybe there are some people in the room, so please use the microphone.
Thank you for this fantastic talk. It's really an interesting topic. I see that more and more companies, for example, are coming on the market with single-use endoscopes. Yeah? But if you ask them about the waste they produce, because we are having, for example, in our hospital, more than 100 endoscopies a day, yeah? What do they claim? And they say, this is more green, because even you don't have to clean the other instruments. What do you think about that?
I think, and I discussed that a lot with them, is more green if you do it in the proper way. The problem is we don't do it in the proper way. If you take it and put it in the right place and it's being taken to the right place, it will be green. The problem is that we don't do it the proper way. So I'm not going to discuss to these companies about that, but it's true that you need the infrastructure behind to do the things in the proper way.
Thank you.
Thank you, Salva, for your talk, and it's a real pleasure you to be here. I think maybe the technician you are talking about in the hospital could be Save the Planet technician, somebody who take care anytime about this environmental aspect. I start recycling because of my kids. So when I am in the operation room, I'm doing nothing. So you are a chief of department, you have a meeting, I don't know, maybe one time every month or maybe one time every year with all the chiefs in your hospital or your manager, whenever, talking about these aspects?
No, not yet. To be honest, 15 days ago, I sent to the manager or director a whole book about my sustainability and innovation project. So this is the title of the project, Sustainability and Innovation. Let's see, I'm doing my best, but it's very complex. It's very complex in, my hospital like yours is 50 years old hospital, the infrastructure of the hospital, there is no, so the new buildings are totally different to the old buildings. And there is a lot to be done, but the first thing I think, the manager director of the hospital has to be conscious about that. I think this is the key. And I'm pushing them, but let's see what I get.
Thank you very much for that. Thank you for opening our eyes and for setting the scene on the future. So in the interest of time, we will move on to our next speaker. And that will be Mojo Faison-Roy, who's going to talk to us about the future in bariatric training, and we're going to get the young IFSO view, which I'm sure also has a view on an environment as well.
Thank you very much for this great introduction. I'm very long associated with Young IFSO already. As you see here, already more than 6 years, and I'm currently the president. I'm finishing my term this year. And just the Young IFSO structure, so we are a worldwide organization under the umbrella of IFSO. We have representatives for each country and then different kind of committees with their chairs. And before I talk about the future, I want to talk a little bit about the current status of MBS training. And the Young IFSO group has has published 2 studies on this topic, one on laparoscopic and one on endoscopic training, and I want to present it for a minute here. So the laparoscopic one, the aim of the study was to find variations and trends in metabolic and bariatric surgical training, and also this was one of the goals to standardize the training in the future. So we had participants from all over the world. So this is a worldwide view, and this is, I think, one of the interesting results of this publication. If you look to first laparoscopic surgeries, then you see here majority of the residents are doing their first steps and the first teaching procedures within the first year. Some of them in the second or third year. But if it comes to bariatric surgery, you see here that the majority of the participants of the survey haven't done any bariatric procedure within their 6 years of residency. Some of them have here in the third or fourth year, but the biggest bar is non-performed bariatric surgical step or procedure within this residency time. But when it comes to bariatric procedures, then it's all about the sleeve gastrectomy. As you see here, first step of preparing the stomach during the sleeve gastrectomy or stapling a sleeve, but only a minority are doing some anastomosis or some preparation of the pouch. Also very interesting, any kind of simulation or training is not mandatory in most of the hospitals. As you see here, in over 70% of the hospitals, you don't have to perform any training before you go to the patient, which I think is not really very well. And the second study that I also want to show here is about endoscopic training, and this is maybe even more interesting because endoscopic training is not included in all curriculums worldwide, and you see here that the majority of the participants, 38%, or the biggest group, let's say it like that, are not doing any endoscopic diagnostic or any endoscopic procedures within their residency time, which means they don't have an education on that. So this means not one endoscopic diagnostic or a procedure within the 6 years of residency. Also, as you see here, the majority have none of this training and simulation probabilities. Yeah, some have some simulation, some dry lab, but the majority not. But what does that mean? That future surgeons cannot really treat their own complications. You see here, only 16% of the bariatric surgeons that have finished their residency can do some endovac treatment, or only 30% some stent placement or some balloon dilatation. Yeah? The majority don't do that at all and always have to wait for the gastroenterologist. If they need something from them, have to make an appointment for their patients. And if you think about the endovac treatment that you have to change every 3 days for maybe weeks, yeah, this is something that is, in my eyes, a little bit annoying. And I want to present you a concept that we have at the Medical University of Vienna because I think it's a kind of role model. We are starting really very early with the education already in the phase when their students are interested in surgical treatment, some theoretical knowledge, preoperative management, but also the planning of the operation, and then the residents immediately starting to assist. And in the second or third year, some of them already in the first year, they are doing some steps of the operation, yeah? Sleeve gastrectomy, or also a gastrojejunostomy. And the majority of our residents that are interested in metabolic and bariatric surgery are able to do a bypass when they are taught, or sometimes even 2 residents together when the consultant is not far away within their residency time. Yeah? And this is possible. And yesterday I heard a talk by Bruno Tillemans, and he has nearly the same concept when he is teaching their residents and their fellows. So how we start, yeah, we have some theoretical learning. Of course, they have to pass that with some background videos, the practical steps of the operation, learning your instruments, very important. If you don't know what you have and what you can use, you cannot really do the operation properly, with tips and tricks, pitfalls, all the functions. Also very important, training facilities. Yeah, we have a room, or we have more than one room, is like a center that you can use 24/7. So all our residents, when they have some night shift, when they are between the operations, they are going there, they do some training it don't really look very spectacular, yeah. And I thought about, okay, I will want to talk about the future. I can tell you anything about AI and everything. And yesterday we had a very nice talk with Daniel Guerro about AI in future training. But I think it's also a little bit come back to your roots, learn how to suture, learn how to use your instruments. And if you have these facilities 24/7, I think this is something that is very important. And we also have some kind of exchange of these tools with other hospitals. For example, a few weeks ago, we got this Medtronic one, but they will give it to another hospital in a few more weeks. So this is some kind of learning in a protected environment. It suits also to most of the students and residents in their life, so they don't have to do some extra training. But on the top on that, I think it's also very important that you have some courses where you really can train. We are doing that on human cadavers and sometimes on animal models, really in a real-life setting, where you have human cadaver, we have some teaching videos before, and then you really do the operation like you would start. So we do this the entire day. These are fresh frozen catheters. We are starting normally with an hydroplasty, doing a sleeve gastrectomy, then we are converting the sleeve to an OHGP, then we are adding the tracheotomy and doing Roux-en-Y gastric bypass procedures. These are our residents that are currently rotating here. They can do all the steps of the operation, and we are doing that normally 3 to 4 times a year. So they have a continuous training before they really go to the human and do these operations. And I think this is also very important because there was also discussion if residents start so early, what's about the complication rate? But it's not really high, and this is also something that Bruno Dillemans very clearly said. If you don't do anything the entire residency and then you're there and have to do it completely alone, I think the complication rate is much higher than when you have some kind of structured learning under the supervision of some consultants. And on the top on that, we also did some young IFSO courses. We have now already 3 to 4 a year, where we really have some kind of endoscopic training, robotic training in a 3-day course, and this is something that is very well attended. Laparoscopic training, as you see here. The next 2 courses are planned already in June and July, one for everything and the other one for endoscopic training. And to conclude this talk, I just want to say I think the future here is that you really start early with bariatric surgical training, even during your residency, with some steps. I think some steps of the operation can be always done under the supervision of the consultant. Also very important is the 24/7 access to training facilities, and it must be mandatory that you have some kind of simulation or some training before you go to the patient, because you want to have some safety. You cannot learn how to stitch when you're the first time on the patient. I think this is very important. So in terms of animal or human cadaver labs, and I think this is more and more coming, but in some countries it's not even the curriculum. Endoscopic training, at least diagnostics, yeah, but also treatment of your own complications should be a part of the curriculum. And this was a huge discussion also in our Young IFSO group, because even in some countries, in central countries in Europe, it's not implemented there. And there was a discussion, why should we as a surgeons do that when the gastroenterologists are specialized there? But on the other hand, we have to be the one that are specialized in that, on our view. So if you want to sign in for Young IFSO, you can do that on the IFSO homepage. Thank you for your attention, and just an advertisement. The next IFSO European Chapter Congress will be in Munich together with IASO, and I hope some of you will join. Thank you very much.
Thank you, Moritz. I have to admit that nothing makes you feel older on a Friday morning when you realize you're a member of the not so young IFSO, as I am. But I'm inspired by seeing what the training looks like. Any questions from the audience?
I think you raised an important point that surgeons should be able to do endoscopy themselves, but per country that's quite different, because in Holland all the endoscopies are done by the gastroenterologist, and surgeons don't get access to that. You need to do many procedures to experience that. And I was fortunate that in my training time, we were doing all the colonoscopies and things like that. So I learned to do it, but the new generation don't get access to that. So how do you solve that?
I mean, of course, this is a point. We are really started that, this was under the lead of Gerhard Prager, that he wants to have some, for example, endoscopy immediately. And when they not immediately come, then we do it ourselves. Yeah. So, for example, we are doing, after every bariatric procedure, we are doing some leakage test on endoscopy ourselves. Yeah. This was the first step. Yeah. We are doing some preoperative treatment.
But then you have to own your own endoscopes because the gastroenterologists have the endoscopes and they'll give it to you.
I mean, we have it in the OR, and I know that some countries, also Switzerland, have the same problem. But Italy already, as I know, have started with that, have some education. I mean, this is a process, yeah, but we really think it's very important to keep it in our hands. Also the endovacuum treatment, yeah, we are a center where we treat lots of patients of endovac because they are coming also from other regions, other countries. And if we cannot see the progress ourselves, we don't know, should we change to a stand now? Should we maybe try to have a VAC stand or anything? I think this is a very important message, if possible, yeah.
If I could make a comment on that. So in the UK, we do our diagnostic endoscopy, but we're entirely regulated by gastroenterology organizations. And I think that theatre is the operating room, is the space where you can do your endoscopy without being regulated as much. Because the reality of it, as you say, no gastroenterologist wants to be there on every sleeve gastrectomy you do, and they definitely don't want to be there on Saturday night when you're doing an endoscopic VAC at 11 p.m. I was going to ask you a question because I know that you are part of the faculty for the divorce course, and of course, Romana Snyder is here as well. And you know, I see it as a hands-on course that really is really positive. And I was just wondering, what are your thoughts about the kind of hands-on courses beyond Young IFSO that are out there? What do we need to do to make them more available? What do we need to do to make sure that they exist in every country?
I mean, difficult. I mean, the largest centers, they have to offer that, of course, yeah. But we are also, as the Young IFSO group, really try to force that. We have now this group. We have also now some kind of contact with the companies that really help us, the local distributors. And we try with our courses, and they are really very well attended because we offer everything in 2 or 3 days, from endoscopic suturing, laparoscopic, robotic, plus scientific workshops, and try to really rotate in different regions. So we have now one in Naples, the next one is in Bucharest, the one after that is in Alexandria, so we really help the centers to set it up. We have a concept for that already, and we try to bring that in different regions of the world.
Thank you. Very good. Are there any questions from the floor? One last question, if I may. You have an unbelievably nice program, including surgery on fresh frozen corpses and animal labs. Who is paying for that? Because that is extremely expensive, at least in the Netherlands.
It is, yeah. Actually, that's paid from the companies. So normally we have 4 to 6 human cadavers, so fresh frozen cadavers, if you want to operate on them, because they have also some autolytic effect. You have to take them out and immediately operate on them. And we normally have the concept that each company pays for 1 human cadaver. So they provide everything for this station, so the students can switch from one to the other and try everything. But the companies, of course, want to sell their products, yeah. They want that we are able to use their Signia or whatever that they have, yeah. And that's why they are always sponsoring one, and then the costs are shared between 5 or 6 companies, yeah. That's how we're doing that.
Well, thank you very much, and hopefully many more people can share your experience. But we will continue for the next talk, and you can go to your next appointment. The next talk is given by Romano Snyder, The Futuristic View on AI and Bariatric Surgery. It's not the future anymore, is it? AI is now.
Well, thanks for the introduction and for the invitation to do this talk. I'm very happy to be here today. And what you said is exactly right. So that will be main part of the talk. So we'll talk about things, how they are now. But I also got this task to kind of look or try to look into the future to see what can be done and maybe to get even a perspective on how it will be in 5 or 10 years from now. So if you read the news, we probably will have much more time to do meetings like this meeting today, and we won't spend much more time in the operating room because Optimus Generation 2, according to Bistomosk, will be able to perform surgeries better than every human surgeon that ever existed in the world in 3 years from now. So it may cause some threats, some panic, some thoughts in some of us, but I think we're a little bit far away from that. So when we talk about AI, we need to understand what is there, what is available, and I think it's nice to kind of separate it into 3 main pillars. The pillar on the left is the machine learning, which is a tool that is around for a few years now. So there are like lots of publications, there is a lot of applications, not only in metabolic bariatric surgery, but also in surgical medicine in general. Machine learning basically is like an algorithm, a complex algorithm that includes data, clinical data, laboratory markers, imaging, so multiple different things. And similar to an older algorithm, it kind of gives you information, prediction, for instance, on weight loss concerning metabolic bariatric surgery or obesity treatment in general. The difference to those older algorithms, and basically every score that we have is also something similar to an algorithm, is that those machine learning applications, they learn over time. So when we use them, they get better. The second big pillar is computer vision, which is also, I think, coming more and more, but it's not as developed as machine learning. So computer vision means that we show an AI application some videos or pictures, and they can recognize tissue, they can recognize maybe our surgical instruments, maybe a procedure. And the last is the generative AI, which we probably use some of us weekly or some of us even on a daily basis, which is like ChatGPT, Gemini, or Claude. Large language models save us some time, can generate some texts, can also generate some texts from videos or pictures. So those are the main 3 applications or big groups of applications that we can use right now. But why is it important for us? Why is it important for bariatric or metabolic surgeons? We know all that obesity is extremely complex and chronic disease, and we don't understand each individual patient in detail or far away from that. The outcomes are also like heterogeneous. So we know from trials like the SMBOSS trial, we have like always a good average weight loss. But if you look at each single patient here in this diagram, which represents a great line, we can't really predict the weight loss outcomes just based on BMI or maybe other demographic data like sex or comorbidities. Also, surgical procedures are extremely complex. We know there are more and more primary surgeries. They get more complex, and we got also more redo cases, and I think this will increase over time. The follow-up is the last, which is probably at the end the most complex, even complexer than pre-op, is the post-operative course. And all of those different stages in a patient's life can be or are subject to help of artificial intelligence applications. So they asked 68 bariatric surgeons, experienced bariatric surgeons from 35 countries, what may be possible implications for AI. And the pros were that AI may enhance surgical skill evaluation. It can help us identify the right patient for the right procedure. It could also be a tool, and we heard that yesterday from Daniel Gero, for education. And they also thought that AI-driven robotics and AI-integrated genomics are the most promising future developments that we don't have so far, but may be available in the next couple of years. The cons and the fears of those surgeons were also, like, we may over-rely too much on AI. Every one of us knows that when we enter some sort of questions into ChatGPT and the algorithm doesn't really know about it, it starts inventing things, so-called hallucinations. And we need some ethical guidelines that are not yet there. Also, they were afraid that if they include AI into informed consent and the patient gets information, for instance, about the surgery or some sort of procedure, what happens if the information was wrong? Who's to blame at the end? So where are we now? As we heard, we are already in the future. In the preoperative setting, there are some patient selection tools, procedure matching tools, and risk stratification. There is some complication and weight loss prediction, which we will see in the next few slides. We have some interpretive tools already, surgical face recognition, real-time augmented guidance, and technical error detection. Post-operative, there is some complication prediction tools, and also there is a nice tool that was already published in 2020, machine learning tool who predicted a 10-year morbidity mortality model in patients with or without metabolic surgery and compared it. If you look at the phases that are investigated, however, when we look at the studies that are done, 45% of AI-focused studies focus on outcomes, and only about 25 and 22% focus on pre- and post-operative topics, and only a little group of 8% focus on the surgery itself. This is a nice trial, the SOPHIA study, which included more than 10,000 patients, 12 centers in 10 countries. This study also includes cohorts from the Sleeve Pass and the SMBOSS trials. And those others made a nice machine learning mechanism that predicts outcome of BMI 5 years after surgery. It is a very simple to use web interface. Everyone can do it, it's for free. You enter weight, height, age, smoking status, and diabetes status, and you enter the type of surgery that you perform, and you can show the patient a real nice kind of prediction on his weight loss trajectory over the years compared to this 10,000 patient data, which is, I think, a real nice tool and implication on how we can use, for instance, machine learning also in like kind of predicting our patients how their result will be after surgery. For the surgery itself, and this, as I said, it's the smallest part of research, but I think it's one of the most interesting things that is going on right now. This is not metabolic bariatric surgery. This includes cholecystectomies and appendectomies. It's a study where they showed some videos of surgeries to an AI algorithm, and it recognized in almost all the cases, it recognizes clips, the retrieval bag in the cholecystectomy or appendectomy, active bleeding, and not all the AI mechanisms recognized it the same, but some gauzes. For instance, when you kind of put a gauze somewhere and you don't remember where it was, it may be an implication to ask the algorithm, where did I put it and where do I need to look to find it again? The next step then is procedure specific. So this is for Roux-en-Y gastric bypass. One of my colleagues from Basel, Joël Lavanchy, made this very nice AI algorithm. And first, what you need to do, and it's always important to get some human input in all those sort of things, you kind of need to define what happens during a gastric bypass. And there are different phases. The orange ones are phases that are always happening, like trocar placement, retractor placement, like the pouch creation and so on. And there are some like facultative steps that they also included in their algorithm. And then they taught an AI to recognize those phases. And they showed them videos of gastric bypass surgery. And in 3 years, we have robots that maybe are able to operate. However, nowadays, there is a recognition of steps in a surgical procedure like a gastric bypass with the 85% accuracy from a data set from Switzerland and 90% accuracy from a data set in Strasbourg. So we are quite far in recognition of surgical steps, but we're not at 100%. Another interesting work was not related to metabolic bariatric surgery, but in general to laparoscopic surgery, and I think this is highly interesting. An algorithm that recognizes like small, like those micro complications we all know about. For instance, like thermal injuries, bleedings. You see, like it recognizes like the severity of the bleeding intraoperatively. It sees like small thermal injuries that you do that you may miss when you count the bowel or kind of touch the small bowel with your harmonic scissors, and kind of would be able maybe in a few years to give you a hint. Please check that piece of small bowel again. You may have a thermal injury that may cause complications in the next few days. Last but not least, the large language models like ChatGPT, Gemini, or Claude. Of course, they can be used as well in our clinical practice for patient education, triage, documentation, and clinical decision support as well. But we already said that we know that there is this hallucination risk. For instance, when the algorithm doesn't know something, it may just invent, even with some sort of papers he cites that never existed. I all saw that before. So what about the future? And who better to ask than AI itself? The future may be precision bariatric medicine. It's a very wild and complex slide, but the idea is that we enter patient data, multiple different parameters, and we get like one model that predicts, personalizes, and prevents the outcome. So this is a so-called precision bariatric medicine model. And at the end, we should be, or we could be able to get some information on should we treat the patient with medication, endoscopy, bariatric surgery, does he need revisional surgery in the course? And all this should be included into one like complex algorithm. However, I think we need to be a little bit more careful because there are some challenges on the way. I think this is extremely nice work that got published in the New England Journal of Medicine, and it shows something that is logical, but needs to be thought about precisely. So whenever we get some new tools that may influence our clinical practice, we need to think about what is the impact. So if we have patient education, the risk of this tool not working properly is basically a miseducation of the patient. However, when we use medical tools for diagnosis, we may risk to get a wrong diagnosis or miss a diagnosis. And when we get the medical application to tell us what sort of surgery, for instance, or intervention we do, we may even end up with the wrong treatment of a patient that goes over years or decades. So at the end, the higher stakes the application has, the more we need validation of the application. And validation is the biggest problem in AI research right now. So 80% of the surgical AI studies are validated only in the institution itself. There is no consistent reporting of the outcomes of an AI study, and there is most certainly a lack of prospective clinical trials. What we need as IFSO, as a society, we need somehow, and that there is no way around, demonstrate the clinical efficacy or not efficacy of AI in metabolic and bariatric surgery. And to do that, we need multi-center prospective validation studies, we need standardized reporting, and we need shared high-quality bariatric surgery data sets, including AI. Take-home messages: AI is already transforming bariatric surgery across the entire clinical pathway. The most promising frontiers, most certainly precision patient selection, intelligent intraoperative guidance, and dynamic digital follow-up. The ethical frameworks and rigorous external validation are non-negotiable. And I think that for all of us that are a little scared about the future, that the future is not AI versus the surgeon, but it's AI with the surgeon. Thank you very much.
Thank you for this intriguing talk. Are there any questions from the floor? AI, of course, is still a big challenge because you need a lot of data to validate the models, and rubbish in is rubbish out. So how do you control that what is going into the system is really what the system should use?
Yeah, that's a good question. So I think one of the big advantages is that one of those algorithms is possibly able to see more surgical videos than we as a single person will be able to see in our lifetime, right? So and probably in a few minutes at some point, right? It's a big amount of data, but you can just.
But there needs to be something that tells the computer this is what you should look for in the video.
Yeah. So that's probably one of the biggest flaws, because at the beginning you need kind of a human being to tell the algorithm that this is the right video to look at. But maybe if you look at millions of videos, maybe the algorithm can learn by itself what is the right way to do it and what is not. Because like just on a basic, like theoretical way, it will be able to watch more videos than we in this room together will be ever able to watch.
Calvin.
Yeah, you know, the more I watch YouTube, the more I'm addicted to YouTube. And I like the fact that YouTube knows my profile, and they keep sending me pictures or videos of cats beating up dogs and things like this, because it knows my interests, right? The more I use ChatGPT, and I don't use it a lot, but I began to notice that it starts feeding me prompts based on what I ask it. And I began to think, well, rather than relying on AI to eliminate my bias with respect to choosing the right operation or algorithm for a patient, it seems to be learning what I'm already doing. I'm wondering if, and it's never been addressed in any talk, whether or not these large language models actually are inherently biased based on what you're asking, and in fact have the opposite effect. Do you have any thoughts on this, about how these models might actually bias you in the opposite direction because it knows your profile and personality?
Yeah, I think that's also a difficult question, and one of the most I think one like tech guy once told me, was not into medicine, is whenever we use something for free, it's also Instagram, Facebook, ChatGPT, we can use those applications for free. So there must be some sort of product behind it, because when we don't pay it, like there needs to be some money going to the system. So we are the product of those applications, and what we need is, and this is like on the side, we need some decentralized applications, because ChatGPT is fed with information, and ChatGPT is also taught to read you and get your personal kind of interests, and it will also give you the answers that you like. And you kind of like, there are even people getting relationship advice from those applications because they know that they will hear what they want to hear. So we need some sort of like decentralization in this, which is an all different topic. But there exists some like decentralized AI algorithms as well that won't do that. Kind of won't sell you as the product, but kind of just be completely truthful.
Roman, I'm going to ask you a quick question
Yeah.
just before you go. This is a session where we talked a lot about green surgery. AI consumes huge amounts of energy, and there is an environmental impact.
Yeah.
How do we square that? How do we address the fact that all these models are great, but they're spending huge amounts of CO2 and energy?
Yeah, I think that's a big problem, because like some server facilities, they use immense amounts of energy. Like, you know, there are some projects in Iceland where they use energy from the earth to kind of heat those servers and give energy to those servers, which are like at the end basically green, which is great. But of course, there is a long way to go. However, as we heard before, I think if you get the optimization of the process, and for instance, what's very interesting, we haven't talked about it, there are some algorithms that recognize when a surgery will end. So at the end, and we all know surgical time is one of the most expensive and also like resourceful things that we have in our hospitals. if an algorithm can recognize the surgery will end in 30 minutes, maybe like call for the next patient, maybe even start preparing everything, we may like kind of compensate those problems that at the end we will be efficient. But that's also like subject to for trials and everything. But it will be highly interesting.
Thank you for providing a futuristic view, but thank you for also answering some really difficult questions.
Yeah.
So thank you very much. And it's now a great pleasure to invite Ann Juti from Finland, who's going to talk to us about green bariatric surgery, which is clearly the only way forward. Thank you.
Thank you, Dimitri. Good morning, everyone, and thank you for inviting me. I work in Helsinki University Hospital, and I am a bariatric surgeon, and I also work on a private clinic. I do mostly bypasses, and I've within the last 20 years, I've shifted the clinic 2 times. So I worked in 3 different hospitals, and each time I've needed to start over the green bariatric surgery. So what is green bariatric surgery? This is going to be a little bit overlapping the first lecture, but I can see that here's more people, so maybe it doesn't matter. Well, it aims to reduce environmental impact of surgical care, such as carbon emissions, waste generation, resource use, and while maintaining or improving patient outcomes and potentially lowering the costs. So sustainable bariatric surgery is providing high quality, high value surgical care in a way that is environmentally, socially, and financially sustainable. And why does it matter? The World Health Organization has claimed that the climate crisis is the major threat to people. And on the other hand, globally, healthcare impacts on total emissions twice as much as aviation. And in developing countries, that is almost 3 times. And operating rooms are highly resource intensive. We use a lot of energy, we generate large amounts of waste, and we involve high emission anesthetics. And to limit the global warming to 1.5 Celsius emissions should be 80% smaller. Globally, by 2050, per person, it should be only 700 kilograms per person to reach the net or zero emissions. And at this moment, we are using in Europe 9,000. And we also, if you choose high-end bariatric surgery choices, it is over 800. So we really have a lot to do. And does your choices matter in OR? Well, we do 600,000 bariatric operations annually worldwide, and carbon footprint can be reduced significantly if you avoid using single-use items, think about the energy consumption, use operating room time efficiently, prefer total intravenous anesthesia over gas anesthesia, and waste management. And even though robotic surgery is very interesting and everyone wants to do it, it uses most resources. So choose wisely which patients you want to do robotically. And think how patients travel to hospital, and do they need to come to the hospital many times, or is only one time enough? And by doing these choices, you can reduce 80% of your bariatric operation emission. And when you do consume less goods, you also save money, so it's also good on that way, and you produce less emissions. And if you choose wisely and work on it, you can get it down to 100 kilograms carbon dioxide emission, which is comparable if you operate 200 patients annually. We do 400, but it depends how many you do. only with bariatric surgery, it would equal up to 3 European persons' annual consumption. And if you choose robotics and if you choose all the high-end goods, then it equals to 17 persons per year. And how to do that then? You can, as we heard in the morning, it starts from the patient preparation, remote appointments and e-learning, one travel instead of several appointments, do several appointments in one day, aim to reduce complication risk pre-operatively already by patient's nutrition and stop tobacco smoking, and do use multidisciplinary, evidence-based, patients-involving methods, and try to choose operation that needs to be done only once, and do it safely and efficiently. Avoid multi-step approach, and make your pathway smooth and flawless. The products you use in operating rooms make 80% of the operating room footprint. It is due to raw material extraction, mining metal and oil for plastic, manufacturing, packaging, transportation, and especially the first two come to labor rights, as mining and production is mainly done in developing countries. Well, what you can do, choose your tool, what you are working, because less is better. You can do it quicker when you don't need to change your tool in your left or right hand. Find good quality reusable tools. It may be sometimes difficult, especially reusable trocars or surgical drapes are extremely difficult to find. Custom make your single-use kits so that you don't throw into rubbish bin unused nothing. Know your products well. It is not always very easy. When I have asked the companies we use that what is the carbon footprint of the, let's say, bypass kit or sleeve kit, I did not get the amount, and I was explained that there is no internationally defined calculation method, so it would make it difficult to compare two competing manufacturers if it's not calculated the same way. And another thing was that they do not know actually the third-party emissions, so we should demand for supply chain transparency. About the waste, try to reduce, reuse, and recycle or remanufacture. Recycle carton, paper, plastic. Then you need in your operating room separate bins, and then you need in your department separate room where that is collected to, and then you need to organize the transport. So talk to your management and educate your staff. For example, J&J tools are wiped clean and then sent to taken apart for recycling. They take out plastic, metal and other parts. And with Medtronic staplers, we prefer that because it's reusable. You can use 300 times most part of it. And some of the simple single-use tools you can actually wash in your own hospital. And then about this remanufacturing, your ultrasonic scalpels can be sent to these companies who make it as new, and then you can buy it back with 50% less money. So that's sustainable and cost-effective. When we started 18 years ago, we got 2.5 bagfuls of mixed waste. Very quickly we started separating those. We separate plastic, cartoon, metal, electronic devices and paper, and we use multi-usable cloth gowns, and so we get mixed waste only half back, so it's 5 times less. And that's done really quickly. It's like not everyday use, what we do every day. And then we get different kind of reports. For example, this is from electric devices. Our hospital sends 2,500 devices for recycling. Just this month, we made a small change to our surgical drape pack. I changed some parts from plastic to cartoon, and then everything was changed from to bio-based material, and we were able to reduce 30% of the emissions by doing just a small thing. And Signia, when it's reusable, then it lessens on that device 38% of emissions. And about the anesthesia gases, talk to your anesthesiologist, as 1 hour desflurane equals to you driving 1,000 kilometers with your car. So ask them to do Tiva, it's like propofol. It also lessens the emesis, the nausea for the patient, and the patient wakes up quicker. So the hospitalization is shorter, and also your turnover time is quicker. And about the heating and ventilation and air conditioning, in our hospital, it turns automatically down after working hours. And use your operating theater that 8 hours that you work there efficiently. Instead of doing 2, make 4 or 5 operations a day. I really highly recommend to read this paper. It's done by the British colleagues. It highlights how surgery can be made sustainable. I like to read it. It was really nice way to do it. And this is your take-home message, step by step towards green bariatric surgery in your operating room. Reduce, recycle, reuse, remanufacture. Choose ecological if you use single-use items. Use the product that has got ISCC certification. Use digital pathways, do multiple consultations on one day, like do the gastroscopy, meet the patient, do the lab, all that in one day. Use intravenous anesthesia. Try to get your operating room turn off automatically, and be an efficient and a good surgeon, not to get complications. But we are not there yet. Still, we need to get either international or European legislation to decide how to calculate the carbon emission on our tools. We need to demand the manufacturers to make reusable items to the market, good quality trocars and surgical drapes. And do ask about the carbon certification. And let's hope we can ski in Europe after when we retire, and so that it's not too hot yet. Okay, do you have any? Thank you.
Thank you for this very interesting talk, and opening up a lot of questions, of course, because many of our disposable instruments can be used multiple times, but regulation tells you that you're not allowed.
No, they don't. Actually, I remember in the 90s, in the 90s we did use them, and then came the European Union and denied it in the end of 90s. But then they made a new directive in, I think it was 18. And I contacted European Union, and they did send me the paper, and we are allowed to use. But then the person or the hospital, if you wash it, then the hospital is responsible for the product. So, but if you use scissors, so what does it matter really? And also the manufacturers, remanufacturers, they are responsible for the product after they have washed it and sent it back to you.
Yes, please.
Thank you, Anna. It was a very, very nice talk. Just two questions actually. First is a short one. Did your infection control doctors allow you to use cloth gowns and reusable draping? Was it a huge fight or a problem?
No, because I contacted Helsinki University. There is 30,000 workers in Helsinki University Hospital, and we use extremely big amount of these single use. So I contacted those people working there, and they started making the drapes. And so they were confronting all the questions, and there were engineers and people who were, so that they were the ones that we are allowed to use and that are safe to use.
Okay. And have you made any technical adjustments to your surgical sort of technique to make it greener or more environmentally friendly?
Yes, I try to use as little tools as because it makes it a lot quicker. You can do it a lot faster. And then I do not use suction at all. I hate that long plastic line. I only take one metal piece which is reusable, and when you stick it into your abdominal cavity, the air seal flow blows the air out, and you can suction with that tool, and it's reusable, and you don't need at all it doesn't get tangled. It's really quick and nice, because it's very rare that you get any bleeding or big bleeding in operation. Maybe those are small little things.
I'm going to ask you a question, if that's okay. When we're all flying back to our hospitals, in the next sort of 24 hours, spending huge amounts of CO2 doing that, and we think about the one thing we can do when we go back, having listened to you, what do you think is the one thing we should all do when we go back?
Make the waste recycling in your hospital.
Thank you.
And then you can clean your kit.
But still, it's a delicate balance, because when you change from disposable gowns to reusable, they need to be washed, they need to be cleaned, they need to be packed, and you need to calculate what is making the best effort.
Yes, of course, but if the forest is cut down and then you make the gown and you in a factory and you send it to the other side of the world and then you pack it and transport, it can't be as bad as washing your, it can't be very bad to wash your own gown in the next room and then wear it again, I think. But of course you need to do it properly, the washing.
Well, if I could make a comment on that, I think that in this field of green surgery, we need to start measuring. We're doing too much modeling, and all models are wrong. Some of them are useful, and we wouldn't be allowed to do that kind of work if it was a clinical outcome. An assumption that it may be better would not cut it. So I think we need to start measuring. Actually, how many miles does it travel to get washed? What's the energy spent to wash? And I don't think we have that data, and I think we should need to start collecting it.
True. Well, thank you very much. Thank you for all the speakers for their very interesting talks, and of course the audience being here to be enlightened in this area, which is very important for the near future, I think. And thank you, my co-chairman, and have all a nice day, and see you back in another session.
See you in the session.